Hello, my name is Daniel Shoskas. I'm the Senior Medical Director of Pacific Edge Diagnostics USA. In this webinar, I'll be joined by Dr. John Sfakianos from Mount Sinai in New York and Dr. Seema Porton from UCSF. And we will be discussing the use of the Cxbladder Monitor Urine Genomics test for surveillance of patients with non-muscle invasive bladder cancer. I will first give a brief introduction to the test, and then the panelists will discuss how they use it in their own practice. So these are the most recent 2020 AUA guidelines for non-muscle invasive bladder cancer. And as we know, there are really only two outcomes. The minority of patients eventually progress and may need a cystectomy, and all those who don't end up on surveillance. Now, this ends up being a large burden of surveillance, both for the patients and for the physicians taking care of them. And indeed, with that large burden, compliance with these guidelines has traditionally been poor. Back when the guidelines were a little more restrictive, a 2011 study showed that only 1 out of 4,500 patients actually got everything they were supposed to. More recently, as low-risk patient recommendations are a little loosened, studies have shown only about 1/3 to 40% of patients actually get all the things they're supposed to get when they're supposed to get them. So can urinary biomarkers help? The Cxbladder urine genomic test is based on 5 genes: the messenger RNA expression of 4 biomarkers related to cell growth, division, and proliferation, and 1 gene related to inflammation. The surveillance patients are checked with the Cxbladder monitor test, as you can see on the top. This takes the expression of those 5 genes and combines it with 2 clinical questions. And that will give a negative predictive value for predicting that tumor is not present of between 96 and 97%. When you compare the sensitivity and negative predictive value with cytology, NMP22, and FISH, in every case, the sensitivity and negative predictive value is far superior with the urine genomic test. This is what a report looks like. There is a cut value of 3.5. And if you are below that number, the negative predictive value of recurrent urothelial cancer is 97%. And indeed, the most recent guidelines from EAU do recommend these tests in the follow-up of low and intermediate risk non-muscle invasive bladder cancer. To reduce the number of cystoscopy procedures, urinary markers should be able to detect recurrence before the tumors are large, numerous, and muscle invasive, and might be used to replace and/or postpone cystoscopy. The NCCN most recent bladder cancer guidelines actually recommends it for the higher risk non-muscle invasive patients. So to explain how they use it in their practice, again, we have 2 panelists. First, we'll hear from Dr. John Sfakianos, Assistant Professor of Urology and Urologic Oncology at Mount Sinai in New York, who will speak on the utility of the Cxbladder monitor test and surveillance. And then Dr. Seema Porton, Associate Professor of Urology at UCSF, who will discuss remote monitoring in urologic cancer, the case for home-based testing in bladder cancer. Dr. Sfakianos.
Thank you for the highlights on the Cxbladder and bringing up the very important clinical dilemma that we face as urologists in treating our bladder cancer patients. And that's really that there is some guidance in how we should surveil our patients, but really the guidance is dependent on which guideline you read and also which expert you actually listen to. There hasn't been really a lot of thoughtful insight in how and when we should stop cystoscopies and how we can incorporate these biomarkers into our practices. So if you see here the AUA guidelines, sort of leave it up to the provider when to stop for the low risk patients. But for intermediate and high risk, they recommend that this should be sort of a forever cystoscopy for intermediate and high risk patients because of the risk of recurrence. But nobody really knows what that risk is. And the EAU has similar considerations, but in the EAU's guidelines, the consideration of replacing with less invasive methods is something that has recently been shown, as you have also shown, that has been updated in NCCN guidelines as well, and incorporating the biomarkers into our practice. But we really don't have sort of guidance on how to do that. Well, the sort of non-muscle invasive follow-up strategies have mostly been using urine cytology and other molecular markers as adjunct or companion tests, but everybody continues to get a flexible cystoscopy. And really it's about replacing the cystoscopy, which is the largest largest burden to our patients who've had bladder cancer. So we want to try to figure out what the best strategy to not miss anything bad, but to also make sure that our patients are not overly burdened. In order to do that, we can use these non-invasive methods in our surveillance schedules. We can stop cystoscopies in very low risk patients or even low risk patients. We can personalize scheduling based on even, sort of intermediate high risk patients, depending on what their actual tumor biology is or their recurrences, et cetera, their comorbidities. Do we really need to continue doing cystoscopies on 80-year-old unhealthy men or women who've had, bad comorbidities, but low risk or intermediate risk tumors? These are all really questions that we haven't really answered. And then to adjust for never recurrence or multiple recurrences, et cetera, et cetera. So what we've looked at is a series of patients based on a population data from the Karolinska Institute. So this is a series of 386 patients. So these are all patients in the Stockholm County in the year 1995, 1996 that were diagnosed with bladder cancer. And these 386 are the non-muscle invasive patients. And these patients have been followed out for now roughly 30 years. And you can see, because of the identification number in Sweden, we can follow patients their entire lives unless they migrate out or something else happens to them. And you can see that of the entire group, that roughly 4.7% of patients were lost to follow-up up to 30 years. So this is a very nicely prospectively studied group of patients, so we know what happens or what happened to these patients. And the majority of these 386 patients, because this is from 1995 to 1996, were really treated with TURBT alone. And some patients had BCG and mitomycin and other things, but the majority were just TURBT. So we know the natural progression and we know the natural history of these patients very well. We can see here in this Kaplan-Meier curve that the majority of these patients who were high risk here, the T1 high grades, did have recurrences, and this is cancer-specific survival, did die from their cancer, but you do see that you have these plateaus of at the end of the curve, meaning that patients who had these high-risk cancers alone, with TURBT alone, never had a recurrence and never died of their cancer. It is also the same for the intermediate risk and the low-risk patients, where there are patients who never have a recurrence after a certain time point. And in this bar graph, we can see here the recurrence by month after diagnosis. And we can see that the majority of the patients who will have a recurrence will likely have that recurrence within the first 5 to 10 years of their diagnosis. If you haven't had a recurrence after about 10 years, very unlikely that you will have one, that the risk goes down. And so we were able to use a statistical methodology called the MELD analysis, where we can sort of predict using the known if you were to run this with 10,000 patients. And you can see in red here, after 5 years, for low-grade patients, recurrences are relatively low. So this is the number of patients out of 1,300 patients, 20 would have a recurrence predicted, and very few would actually go to muscle invasive. Interestingly enough, our high-grade patients, the ones we worry about the most, are the ones that actually do the best. meaning that if you have a high-grade invasive cancer that hasn't recurred within the first 5 years, it's very unlikely to recur or progress. All the bad actors will show up early. And so while we are worried the most about our high-grade cancers, really these are the ones long-term that we could probably consider decreasing our surveillance or using non-invasive methods. So in my practice, I use Cxbladder because I feel that this is the first test that I have confidence that's giving me results that I can use clinically and make clinical decisions in a couple of different ways. For my low-risk patients, those who haven't had a recurrence at 3 years, I will actually just start using Cxbladder, UA, and urine cytology, even though now I've backed off urine cytology quite a bit for these patients as well, instead of cystoscopies. So we can do home tests, which Seema will tell us about in a lot of our patients, save them a trip into the office. If there's anything that's concerning, then we bring them in. For intermediate risk patients, we go out to 5 years, and then we'll start alternating or, with shared decision-making with our patients. If they haven't had a recurrence at 5 years, then we'll just do every 6 months, a Cxbladder, urine cytology, either home or have them come in just to say hello. And it's similar to our high-risk patients, just given the data we have and just from personal experience with these patients. The other important, sort of place that I've been using this is in a situation like this, where we had an 83-year-old male who initially presented with hematuria in 2017. He was found to have CIS of the bladder. He was treated with induction BCG and maintenance for 1 year. Everything was completed right around the beginning of 2019. And then he's been on surveillance cystoscopies every 6 months because he's a very anxious patient. We then, in 2020, identified him as having a positive cytology but a negative cystoscopy. And this is one clinical situation that we've always, everybody has their own opinion on what to do. And sometimes we are aggressive and some people say be less aggressive. Well, interestingly enough, his Cxmonitor test here was actually a low probability of having any cancer, even though his cytology was positive. This patient ended up going to the operating room, getting random biopsies, upper tract evaluation, CT scans. And interestingly enough, his CT scan actually identified a colon cancer, which we caught because of this false positive cytology, and had a colon resection. He ended up having a colon resection. But from his bladder standpoint, everything was negative. Since then, he's been having on and off positive cytologies, but normal Cx monitors. And I've just laid off trying to figure out where this positive cytology is coming from. He just comes in for surveillance and has been doing well. He's actually due for surveillance pretty soon. And I think that now I feel comfortable having this situation happen a couple of times, that if the Cx monitor or detect, depending on which one we're using, is negative, that we don't have to be as aggressive in taking patients to the operating room, doing random biopsies, which we all know already have low sensitivities. So I think that's a very important clinical indication that has now definitely helped decrease the burden on our patients, and also has an adjunct test where we can counsel the patients and be able to make shared decision-making with more information. In a real-world analysis, so we've actually ran this test on 161 patients. We've ran 436 Cx monitor tests. So these are all our bladder cancer patients. And this is the reason why I feel comfortable. One of my mentors always said, keep your data, analyze your data, believe your data, and use your data to make clinical decisions. So this is exactly what we did with this analysis. Looking at our patients, the negative predictive value in our group is 90% for Cx monitor. And interestingly enough, for the high grade, the ones that we were the most worried about, the negative predictive value was 97%. And for the low grade was a little less, as kind of expected, because these tumors are not necessarily shedding a lot of these aggressive markers that we monitor. And so with this, knowing this data, I feel very comfortable being able to use this as an adjunct to cystoscopy in my practice. And hopefully we can have larger data series that we can better identify how to surveil patients and use this in our practices. So in conclusion, understanding the risk recurrence for the various non-muscle invasive bladder cancer risk groups and having a test with a high negative predictive value allows us to now personalize better counsel for shared decision-making with our non-muscle invasive bladder cancer patients on surveillance programs, and actually helps us decrease the burden for our patients. Thank you very much.
Thank you, John. You mentioned that this is now part of your shared clinical decision-making with patients. How do you find the patients responding to this? Are they eager to try something that'll help them avoid cystoscopy, or are they leery of something that may miss a tumor and they really want to have that cystoscopy to be sure?
So I think the overwhelming majority of my patients actually are very eager to use the test and are very happy with actually incorporating it into their surveillance and decision-making rather than having cystoscopy, because most of my patients, I would say, are not fond of the cystoscopies. I do think that there are a group of patients with high anxiety levels that still want to do the cystoscopies and want to do them every 3 months instead of every 6 months. Or if I try to say, let's prolong it, and there's no, I want it. But that's a small minority. But I think the overwhelming majority of the patients are very happy to incorporate it and absolutely love the idea of doing a home test and not having to travel in to see me just to give a urine test. So,
okay. Well, now on the subject of home testing, Dr. Porton will tell us about her experience.
Thank you for having me here today to talk about using Cxbladder as a remote monitoring. I think John touched on some really important points in how we help patients through the surveillance period and rationale for minimizing cystoscopy, and a lot of good data for that. I'll show a little bit of a similar theme with some of our data in using Cxbladder, particularly during COVID, to decrease the burden of surveillance for patients. So there's been an explosion of home tests, both FDA approved and not approved. There's Cologuard for colorectal cancer. There's metabolomic tests. There's anything you want to test, you probably could, along with germline genetics. And so with that, I think patients have gotten a lot more savvy and used to thinking about these as methodologies in terms of their healthcare. So with Cxbladder Monitor in particular, this was built for the surveillance setting. I think, Dan, you went over nicely all of the data on this, and I wanted to highlight the NPV of 0.97 in the study done by Yair Lotan and colleagues, looking at Cxbladder Monitor in this situation where you could possibly consider skipping a cystoscopy and reducing the burden of surveillance in a very select group of patients. And I would say that the one kind of development or change since when this trial was published and run was that Cxbladder is available as a home-based testing for patients now and can be self-collected fairly easily without much. It's not a complicated process, and most of my patients can get through sort of doing it. So right before COVID started, we were talking about considering using Cxbladder as part of an in-home sampling workflow as a pilot project. And I wanted to go over briefly the inclusion criteria for these patients. So non-muscle invasive bladder cancer patients had to be greater than 6 months from a primary diagnosis, greater than 9 months from a recurrence. They had to be more than 3 weeks from a prior urinary instrumentation. So this was voided urine only. And they had to be more than 3 weeks from intravesical chemotherapy and 4 weeks from BCG. They couldn't have had a gross hematuria or active UTI. And this was our main entry criteria. We did not use Cxbladder Monitor to minimize cystoscopy in that early time period after a patient was either diagnosed with a primary or recurrent tumor. And I think that's important. And what we're talking about is trying to minimize cystoscopies after that time period, as the duration of surveillance is not well defined, as John discussed. And the way our workflow is that our clinic identified the patients and filled out the form for Cxbladder Monitor. Pacific Edge shipped them a kit as well as instructions, and that was then shipped back to Cxbladder, and results were sent to our clinic. At this time, we were just launching our telehealth services, which now are kind of become standard. And they would have a telehealth appointment with either our MD, PA, or NP, or physician extenders, to review results. And our goal was to safely reduce the total number of cystoscopies and burden to the patient in terms of personal discomfort, financial considerations. This is time off work for patients, as well as travel. Some of my patients are about 8 hours away, and that is quite a bit of gas money or arrangements of figuring out how to drive into the city, as well as parking. I don't know about you guys, but it's fairly expensive to park at UCSF, and I think the cost of the test might be cheaper than a day of parking. And then also try to increase the use of our physician extenders in telehealth. Well, then COVID hit, and we decided to use the test in a slightly different way. We had this set up as being a pilot study, but we sort of were able to use this to pivot when our institutions mandated that we reduce the number of patients coming in and allocated a certain amount of slots each day in terms of in-person procedures. And so from March 2020 to June 2020, 92 patients who were supposed to come in for a cystoscopy were instead sent Cxmonitor. We had 43 patients in that early surveillance period, meaning within the 6 months after initial diagnosis or 9 months after a recurrence, that were not offered Cxbladder and brought in for their cystoscopy appointment. We also joined together with our colleagues at Michigan, who did a similar sort of an approach. And we had combined our data. And when you kind of look at this, 92 patients with urothelial cancer received Cxmonitor. This is table 1 of our paper, which should be out shortly in urologic oncology, that kind of compares the baseline demographics and characteristics of the population, as well as by site. It is what you would expect, mainly male gender for patients, older, 60s or older for the majority of our patients. Many of our patients were high risk. And so we sort of, it kind of reflects some of our institutional practice patterns. At UCSF, we did have a slightly higher use of intravesical therapy, both peri-op as well as adjuvant. And the number of months from the most recent recurrence was shorter than at our site in Michigan. So this figure kind of shows exactly which patients ended up getting Cxbladder, how many were sort of adjudicated to have an immediate cystoscopy, and how many were able to skip the immediate cystoscopy. When you sort of look at this, we had 24 patients who had a Cxmonitor score greater than 3.5 who went for immediate cystoscopy, and only 9 of those 24 patients were tumors seen, and you can see the distribution there. We did detect 1 patient with an upper tract urothelial cancer when their cystoscopy was clean, but the cytology was positive, and we followed up with subsequent imaging. Cytology alone wouldn't have caught 3 of these patients. When you sort of look at that at who had high-grade cytology that was positive, it was 67%, and 3 had negative cytology or atypical cells. So it's not like we could have just used cytology, which also can't be collected at home. So that would have not been useful in this setting when we're not allowed to bring patients in. There were 2 patients that were eligible to get Cxmonitor, but 1 did not have a mailing address that they could have the Cxbladder mailed to because they did not have stable housing. So we did bring that patient in. And the other was too anxious to do this test and requested if there was a spot that they would prefer coming in for their cystoscopy. So that gets at that the majority of patients, 92 patients were okay with sort of doing this, particularly during this period of COVID. We had a median follow-up of 4 months. Almost all patients had their next scheduled cystoscopy, and no tumor was seen on follow-up. And on this next slide, you can see the results of the sensitivity, specificity, and negative predictive value in this cohort. Our NPV was 1 with a sensitivity of 100%. We did have 1 patient who missed their follow-up. their first cystoscopy after a CX monitor was considered favorable due to concurrent treatment for breast cancer. She was subsequently found to have a high-grade T1 recurrence 13 months later after a negative CX monitor score. You would hope that if we were able to bring in for the next follow-up with a cystoscopy, that would have been detected, but this was the only patient who had missed their follow-up where they developed a recurrent disease not detected by Cxbladder monitor. So this is our proposed algorithm in terms of how we can minimize the burden of cystoscopy in patients with non-muscle invasive bladder cancer. We do use this pretty strict criteria, not allowing the use of this in this early time period, post-primary diagnosis and recurrent diagnosis. And we're working on incorporating this in our new workflow in terms of utilizing telehealth a lot more regularly and alternating CX monitor with in-person cystoscopy. We also did a short patient satisfaction survey. 72% of our patients at UCSF did complete this. They thought it was pretty easy to do. And the majority said that they would do this in the future as a way to skip one of their surveillance cystoscopies. When you ask the 3 patients who answered no, it really was primarily driven by anxiety, meaning that at this time period when it was in the height of the pandemic, they were more worried about getting COVID than their bladder cancer recurrent. So we're okay doing this in lieu of a cystoscopy, but when offered both equivalently, they just felt like they were too anxious to undergo Cxbladder monitor testing and preferred a cystoscopy. And I think that gets to a little bit of what John was talking about, but most patients really did like the ease of this test, did like reducing the amount of times they had to come in for that visit, and really appreciated the ability to have a monitoring test that they were able to do at home. So in conclusion, the pandemic has created changes to healthcare delivery, more telehealth, a lot more people working from home, and as well as rationing resources such as physical space. And we do have a little bit of a new normal in urologic care beyond the pandemic in terms of now tools to reduce patient burden without compromising our oncologic outcomes, reduce cost. And CX Monitor plays a key role in reducing the frequency of surveillance cystoscopy in this surveillance setting, and is acceptable to most patients as a home test.
Well, thank you very much. It may not age well if I say we're in a post-pandemic time, but now that your slots have opened up and the patients are able to come, have you found a persistence of this desire to use home monitoring and avoid that $50 parking fee?
Yeah, many patients who were part of this period definitely they ask about it, and they talk about it in our bladder cancer support group. So I think we have a lot, many more patients wanting to know if this is a possibility for them. And it definitely is if they meet those criteria over in terms of my practice at UCSF. And so we are utilizing it more in reducing burden. We also have some patients who now have just a different work situation or balance. There's a lot more people working from home from other areas, spending half their time in California and half their time out of the state, and a lot more different work paradigms that I'm seeing. And this helps us with our continuity of care for those patients who are working differently now after the pandemic. So I think there is still a demand and desire for this from our patients.
Well, thank you very much, John and Seema. Thank you, Grand Rounds in Urology, for hosting us. And if you'd like further information, there will be a link to our website in the comments. Thanks again.